Hi, I'm Mike Sonic, and I'd like to welcome you to Dental XP. I'd like to share with you a case today about restoring teeth and implants in the aesthetic zone, particularly a 4-unit bridge that goes from lateral to lateral. And how do you go about restoring it? And the patient's chief complaint who came to my office was he didn't like what the bridge looked like. He was very concerned about the aesthetics. He didn't know what was wrong. He's a very bright guy. He owns his own company. He's an engineer. And he knew that something was wrong with this front bridge. What I found is that engineers are probably the best patients to do dental implants on because they know more about implants than we do. Engineers are going to come into the office and they're going to say, what's the best way to restore my mouth from a functional point of view? And hands down, functionally, it's better to have an implant in a dentulous space than to have a Pontic, because it's going to give the tooth its own support. I learned this back in 1987 when I first started doing implants. I had a patient with a very similar situation that came in, and I said, well, we could do it with an implant or we could do a 3-unit bridge to replace the central incisor. The patient had already had a bridge. Well, the patient was a woman. She was there with her husband, and her husband turned to me. He says, why wouldn't you do the implant? Doesn't it make more sense? Won't it be a stronger restoration? And I said, yes, it would. But it was my own fear of saying, well, it's going to cost more money to do the implant, it's going to be a surgery to do it, it's painful, and all the other things I was thinking back in 1986, over 20 years ago, that held me back from saying, yeah, we'll do an implant. He happened to be an engineer, also owned his own company, and that was like close to 20 years ago, and that patient still has that single implant. We've never had to redo a 3-unit bridge. That implant has stood by itself, stood the test of time. Well, as you can see from this patient, there's something wrong aesthetically. You see there's some recession, there's some discoloration, there's altered gingival levels. We'll take a look at this case. Tooth number 8 is missing. It has a ridge lap for a Pontic, so there's a lack of soft tissue and hard tissue in that area. And when you look at this kind of case, I like to think of what I call an aesthetic diagnosis. When we look at patients, we always want to make a dental diagnosis, be it what is a periodontal condition, what is a probe, what kind of bone loss do we have, is there furcation involvement, those types of things, mobility. What's the dental diagnosis? What's the occlusion like? Is it a class 1? Is there malocclusion or balancing interferences? Is there caries? Those type of things we think about. But do we also think about an aesthetic diagnosis? I think it's a good concept, and I recommend that you try that on, that you start to look at cases and you say, well, what's the aesthetic diagnosis? And you do that with the patient. Now, you don't say to a patient, what's the aesthetic diagnosis? What you say to the patient is, what don't you like about your smile? And as they're telling you what they don't like, you start to come away with what I call the aesthetic diagnosis. So let's take a look at this. What's the diagnosis of this patient? Take a look at how the teeth fall within the frame of the lips, the upper and the lower lip. Take a look at the teeth, how they relate to each other. Take a look at the margins of the restorations, and start to think to yourself, what's wrong with this case? By knowing what's wrong with the case, you can take it then step back and know what to fix. Just like we don't pick up a high-speed burr and start preparing a tooth until we know what's wrong with the tooth, we want not to start aesthetic rehabilitation until we put all of our landmarks, all of our steps, everything, all of our ducks in a row, so to speak. So when we look at this case, we want to know what is the diagnosis. Take a few minutes to look at both the relationships of the teeth to the lip and to each other, and in your own mind, start to make a list of what you think is wrong with this case. This list is very important because it's from this list that we're going to come up with our treatment plan. So let's take a look at it. First of all, we all see that there's a 4-unit, 3-unit, or 4-unit bridge up there. There's a bridge that goes from tooth number 7 to tooth number 9 with a single crown, and tooth number 10. It doesn't fit well. There is recession, and you can see the margins. There's also some gingival redness due to a violation of the biologic width and poor oral hygiene. There's asymmetry between teeth number 8 and 9. You like to see symmetry between central incisors. Tooth number 8 is missing. The 9, the gingiva is too incisal. 10, the gingiva is too apical. The incisal edge to the lip line is not very aesthetic. Plus the crowns are yellow, their shape isn't very symmetrical, they look square, they look fairly boxy, and our papillas are not in alignment. So a lot of things about this case don't look very well. Functionally, we have a 3-unit bridge where we could break this case up with an implant if we so desired. So, what's the treatment plan for this case? There are pretty much 2 basic treatment plans for this case. One treatment plan option is to do a 3-unit bridge from 7 to 9 and a single crown and tooth number 10. You could also do a 4-unit bridge from 7 to 10 and double butt, both 9 and 10, and that was very common many years ago. Or you can do an implant on tooth number 8 and single crowns on 7, 9, and 10. This would segmentalize the case, and you'd have individual units. So the question that you have to ask is, why the implant? Now, you're a sophisticated audience. All of us probably feel this is an implant case, but in a lot of parts of the country, this is not an implant case, this is a bridge case. Implants are probably pretty well underutilized today in the United States. So you got to think to yourself, why do the implant? Because at your fingertips, you want to have the reasons why do an implant versus why do a bridge, because patients are going to ask you this. Well, firstly, the implants segmentalize the case. What does that mean? It means it breaks up the case into individual units. So if something goes wrong with a 3-unit bridge, it's a 3-tooth problem. If something goes wrong with a single crown, it's a single crown problem. So it decreases future cost. It decreases the amount of treatment people may need in the future if there's a problem, because it becomes a single tooth problem. The strength of the restoration is increased because now you're putting support back where there's a pontic. You don't rely on the 2 adjacent teeth to support the pontic. You now have an implant in that area. Patients are able to floss. Makes it easier to floss. I have a bridge in the front of my mouth. It's hard for me to feed a floss threader into that area and floss between it. You may ask, why do I have a 3-unit bridge? Well, I don't have enough bone for an implant in that area, and I would need a block graft to do it, and the adjacent tooth's not in very good shape. So I'm waiting for my adjacent tooth to fail, and I'll then do 2 implants at some point in the future. And cosmetics may be a possible benefit. It may not be a benefit also. Those of you who've restored implants know that sometimes cosmetics do help, sometimes they don't with implants. Sometimes it's easier to get a more cosmetic result with a 3-unit bridge. That really is in the skill level of the practitioners. So what do we do for a treatment plan for this case? Well, we're going to do an implant. We've decided that we're going to do that. We've discussed with the patient the reasons that we want to do the implant because of cost, improved function, cosmetics, segmentalization, etc. So step number 1 involves provisionalization. The patient should be into a temporary bridge. Then we'll go ahead and perform our implant surgery. After implant surgery is performed, we're going to go ahead and perform a connective tissue graft on tooth number 10. We can see the gingival margin is a little bit too far apical. We'll then allow the implant to heal, uncover the implant, and place a provisional restoration. So now we have sort of setting up our case, and we're going to start to look at the soft tissue. How does the soft tissue fit between teeth 6 and 11? Well, we're then going to go ahead and do crown lengthening on tooth number 9. This is done once the implant is integrated and provisionalized. Then go ahead and do any dermabrasion or soft tissue work that we need to do, followed by another temp and the final crowns. So this treatment plan that we've developed starts with regeneration. Regeneration of the tooth with an implant, regeneration of the soft tissue, connective tissue graft. Then it goes with the resective procedures, cutting away tissue and bone, making things perfect in our dermabrasion, so we then can go on to a final restoration. The implant surgery is now done after the provisional is in place. You can see the provisional on the upper left. An osteotomy site is made. The implant is then placed, and it's placed 3-dimensionally. Mesial distally, occlusal apically, and buccal palatally. Implant is an ideal position, and then we'll close the case and let her heal. Here the implant is being uncovered, and you can see the position of the implant. It is right in the middle of that spot, maybe a little bit toward the palate, so we can get a nice emergence profile. The implant platform is 3 to 4 millimeters from the anticipated CEJ. Temporary healing abutment is placed. Soft tissue is pushed out to the labial, building up a lot of soft tissue in this area, so we have a nice emergence profile, and then the provisional is placed. At this time, we're going to perform biphasic aesthetic crown lengthening on tooth number 9, which you can see the soft tissue margin is a little bit more incisal, so we want to even 8 and 9, 8 being the implant, 9 being natural tooth. Connective tissue graft was already placed on tooth number 10 some months ago. So here we go ahead and perform our biphasic crown lengthening. And on the left-hand screen, you can see 2 vertical incisions and a little bit of bone is removed, so that this bone is going to be 3 millimeters from the anticipated soft tissue margin, because we want this soft tissue margin on tooth number 8, the implant, to be the same level as tooth number 9. So 2 incisions are made, then bone's removed, ostectomy, it's been replaced. We also did a little crown lengthening on tooth number 7 as well, as you can see. So we did crown lengthening on 2 teeth simultaneously. We'll then allow this area to heal for 6 weeks. Here's the implant on the upper left screen, and our papillas are still present. We then go ahead and perform a gingivectomy. Gingivectomy is performed because the bone has already been removed, soft tissue is healed, and the gingivectomy is performed so that we level tooth number 8 and 9 and tooth number 7 and 10. You can see here's the gingivectomy on the lower screen on tooth number 7. We did a little dermabrasion here as well, and here's a gingivectomy on tooth number 9. 2 to 4 weeks later, this soft tissue will be completely healed, and if we wish, we can go on to our final restoration. I don't recommend that. When you're dealing with implants in the cosmetic zone and soft tissue changes, I recommend that you leave the implant in a provisional for a good 3 months. Because any soft tissue changes that occur, I'd like to occur when the provisional is there, not in the final restoration. Because once it occurs in the final restoration, you can't change it. If it occurs in a provisional, you can alter your provisional restoration to make things look cosmetic. So we're going to go ahead into our final restoration. Here are the provisionals. Okay, this is at about 3 months, and we're starting to develop a good soft tissue harmony. We have an implant in tooth number 8. We've done crown lengthenings on tooth numbers 9 and tooth number 7, and a connective tissue graft on tooth number 10. This is the provisional restorations, and they look good. The soft tissue profiles are nice, papillas are lined up, we've preserved the papillas, and we've created nice harmony between teeth number 6 and 11. So here's the implant, here's the connective tissue graft, and we have 2 areas of crown lengthening as well. So here's the temps. The final restoration should be a recapitulation of the provisional restoration. Here's the final restoration. They look pretty similar, except for the color and texture of the teeth, but the soft tissue looks very similar. We worked out all of our soft tissue in a provisional restoration. So in the final restoration, we now all have to do is recapture what's there along the soft tissue and create the final restorations. It makes it very easy for the laboratory and restorative dentist if this is set up properly this way. So here's where we started, and you can see the alternations of the dental gingival margin. Okay, tooth number 7, we don't like the shape of this tooth. Tooth number 8 is a pontic. 9, we need some crown lengthenings to make it look a little bit better. Because it's too square, we want to make it look a little bit more arcuate. Tooth number 10, as you can see, we don't have enough soft tissue there. Tooth number 10 is almost as long as tooth number 11. So here's the final restoration. As you'll see, if we draw a line between tooth number 6 to 11, as I've learned from Dr. Kois many years ago, you'd like to see the canines on the same line as the central incisors. The lateral is a little bit beneath it. On this line, you can see the lateral on tooth number 10 is above the line. Tooth number 7 is in the right spot. Tooth number 8 is above the line. Okay, tooth number 9 is in pretty good shape. It probably could be a little bit longer. And then in the final restoration, when you draw a line between 6 and 11, things lay pretty nicely. Maybe tooth number 7 is a little bit too long. Probably should the crown lengthen that side. But in all, things look pretty good, and we have a nice soft tissue profile. And our single implant restoration, tooth number 8, blends very nicely, very harmoniously with the adjacent teeth, and we have a nice aesthetic result in this case. So here's where we started, here's where we finished, and we end up having relatively happy patient. So again, before treatment, altered dental gingival junctions, and the final result. So thank you for your time, and hope I was able to illuminate a couple of interesting points on the anterior aesthetic zone. And in closing, all of your treatment comes from your diagnosis, your aesthetic diagnosis. You start with your diagnosis, you develop your treatment plan, and then you work your plan, paying attention at each step to make sure that the treatment that you have dictated heals appropriately, etc. Sometimes you may have to make some alterations. Thank you again.